Okay, we're gonna start recording. Oh, hang on, it's gonna ask me to log in and all of that. So your guys' grades right now are still with your homework turned on. It will continue that way until next Monday, okay? Then week 8, I shut them off. Okay, so you guys can kind of see where you're sitting now. There are a couple students who didn't do their CJ Sims from last week, so make sure you guys get those turned in by Sunday, so that way you can just miss a few points, 10%. And then also there was a couple students also who didn't have their NCLEX questions completed, so make sure you guys have those. Okay, if you guys can all join me as soon as it says our PIN number. And since we are doing Cahoots for lecture, I need you guys all to join me, okay?
One more question.
Uh-huh.
On the one from the quiz with the penicillin, was it penicillin? How many years should they have gotten that injection?
Sorry, you kind of were a little bit, I don't know if your sound was off for a little bit, but I only heard part of that question, something about penicillin.
It was the one with the injection after rheumatoid fever or something.
After rheumatic fever, yep, if they have rheumatic fever. Mm-hmm.
Right. How many years were they supposed to get that injection?
It's 5 years, at least 5 years. So
Okay.
if they have cardiac involvement, the guideline is now actually 10 years, but 5 years is standard of treatment.
Thank you.
Okay. Yes, you're welcome. All right, let's make sure everyone's logged in here to Cahoots. Looks like a couple more of you guys need to join me. You guys did a nice job on your exam too, by the way. Okay, I need a couple more of you guys to join me. Okay. Alrighty, we're gonna go ahead and start. Okay, so chapters 27 and 28, okay? Okay, which finding in a newborn is suggestive of tracheoesophageal fistula, or TEF? This other name you'll see. Palpable mass in the sternal area, visible peristalsis along the abdomen, failure to pass meconium in 24 hours, or choking on the first feeding. Good job. Yeah, choking on the first feeding. And we'll talk a little bit more about that, but essentially that means the trachea, the opening is into the esophagus. So there's kind of an opening, an abnormal opening, instead of the trachea having its own path to the lungs and the esophagus having its own path to the stomach. Okay, child has been vomiting for the past 2 days. What acid-base imbalance would the nurse expect? Hypernatremia, acidosis, alkalosis, or hyperkalemia? Alkalosis, yes, because vomit is acidic, right? So if you're throwing up, you're getting a lot of the acid out, which means your body is going to stay basic or alkaline. Does that make sense? Okay. Okay, hereditary blood disorder that the body does not produce enough adult hemoglobin. Thalassemia, hemolytic anemia, sickle cell anemia, or ITP, which is idiopathic thrombocytopenic purpura, is what ITP stands for. It's thalassemia, okay? You can see beta thalassemia somewhere, but it's thalassemia is when you don't have enough of an adult hemoglobin produced. Good. Why are rapid respirations a possible cause of dehydration? They prevent the child from drinking. They cause evaporation of fluids on the mucous membranes. They increase circulation, thus increasing urine production, or they often lead to vomiting. They cause evaporation of the fluid on the mucous membranes. Yes, exactly. Also, if a child's breathing really rapidly, they're probably not going to drink very well either. But the biggest cause is the fluid evaporation. Good. What would the nurse expect the parents to report with a child with or an infant with pyloric stenosis? Projectile vomiting, diarrhea, constipation, or poor appetite? Projectile vomiting, it goes along with pyloric stenosis, okay? And parents will tell you projectile vomiting sometimes if their kid's just spitting up regularly. But with pyloric stenosis, it's literally like the kiddo can be, in the middle of the room and almost hit the wall like that. It's that forceful with their vomit. Okay. Okay. A multi-select. How would you treat chronic constipation in children? Add high iron foods, adding more raw vegetables, increased cooked vegetables, and increasing fluid intake. Which of those things would you do to help with chronic constipation? So, adding more raw vegetables, okay, and increasing fluid intake. If you cook the vegetables, they lose some of their fiber benefits, kind of cooks out of it. So, those aren't as beneficial. But yes, raw vegetables and increasing fluid intake. Good. Child has been scratching the anal area and complaining of itching. What should the nurse suspect? Gardiasis, pinworms, ringworms, or roundworms? Pinworms, okay? If a kiddo's itching at their bottom, they can either have strep around their bottom, which you can have anal strep, okay? Or pinworms. And how you figure out pinworms, this is the most logical way, I guess, or the most common way, is pinworms usually they come out a little bit of the anus at night. So what you can encourage parents to do is put a little piece of Scotch tape kind of across their bottom, so across their anus, right before they go to bed. And then a lot of times then in the morning, if it is pinworms, you'll see a couple little white pinworms on the Scotch tape, which I know sounds really gross, but that's one of the most common ways that they're diagnosed, other than just hearing about they're having a lot of anal itching. Okay. But like I said, they can also have strep around their anal area. So if kids have strep around their anal area, it's like a fire engine red circular rash right around their anus.
How do you get pinworm?
From the dirt. I mean, they can get it from anywhere. Other kid, like playing with other kids that have it, and then itching their bottom or touching their mouth.
Oh, okay.
But the eggs are most commonly in like dirt and things like that. What instruction will the nurse give to parents about preventing the spread and reinfection of pinworms? Keep the child's nails short. Wash their bed linens in cold water. Clean the bathroom with bleach. And dress the children in loose-fitting underwear. Keep the child's nails short, and that goes along with not spreading as easily if the nails are short. Because otherwise, if the nails are long, then they could potentially, when they itch their bottom, they could get like an egg from the pinworm, essentially, and then touch things and spread it that way. Okay. Okay. Which food would the nurse recommend to include in a child's diet who is frequently constipated? Whole grain cereal. Yep. Because remember, the cooked vegetables, they lose some of their fiber value. Arnisa, are you driving, my dear? Oh, you're muted. If you're driving, I'll have to have you log off and then you can join again when you get to your destination. But if you're just sitting in your car in the driveway, then that's fine.
I'm gonna rejoin when I get back.
What was that? I'm sorry.
I'm about to log off.
Okay. Alrighty. Thank you. Okay. So whole grain cereal. Okay, what condition is characterized by pain in the right lower quadrant at McBurney's point? Hirschsprung's disease, intussusception, appendicitis, or Kowsker? Appendicitis. Yep, good. All right. What description of a child's stool characteristic leads the nurse to suspect intussusception? Currant jelly, greasy and foul smelling, green liquid, or black and tarry? What kind of stools will children with intussusception have? Current jelly stools. Remember the greasy, foul-smelling stools? That is most common in kids with cystic fibrosis. Okay. So if they have intussusception, they're going to have current jelly-like stools.
What is suspect?
Oh, sorry. We'll talk about it after this question, just since I skipped forward. What does the nurse expect the appearance of the stools to be with a child with celiac disease? Loose and foul smelling, ribbon-like, hard and constipated, bulky, and frothy. Bulky and frothy for celiac, which is gluten, issues with gluten, okay? So intussusception, that is when the intestines, they telescope on each other. So essentially one portion of the intestines decides it wants to change positions in the abdomen. So essentially it rolls back into the other portion of the intestines. Then you get a big bulge buildup of intestines. So it kind of telescopes on itself. So you know how like a telescope collapses, right? You can fold a telescope up. That's essentially what the bowels do. So they kind of collapse into each other. Okay. All right. But with celiac disease, you're going to see bulky, frothy stools. And celiac goes along with gluten intolerance. Okay, a 7-month-old is admitted and diagnosed with acute gastroenteritis. What will the nurse's priority goal be? Prevent malabsorption, prevent skin breakdown, prevent fluid and electrolyte imbalance, or prevent nutritional deficiency? Fluid and electrolyte imbalance, because gastroenteritis is usually when they're throwing up and having diarrhea. So they're losing their acid and their base. Okay. And they're really at risk for dehydration. After surgery for pyloric stenosis, an infant is hungry and crying. What is the most appropriate nursing action? Allow 1 ounce of glucose water at frequent intervals, delay feeding of the child for 6 hours, offer regular formula thinned with water, give small amounts of regular formula thickened with cereal. Yep, so you're going to start with glucose water at frequent intervals, okay? Make sure that they can tolerate some clear, less harsh to the belly liquids before you start feeding them formula or breast milk. Okay. All right, a multi-select child is brought into the ED with suspected appendicitis. What are signs and symptoms? Guarding, pain when lifting the thigh when supine, rebound tenderness, and left lower quadrant pain. Which of those are correct? Okay. Pain on lifting the thigh when supine. Okay. And then also rebound tenderness. Good. And it's right lower quadrant pain for appendicitis, remember? Good.
And is it only the pain only in the thigh when they're supine?
Nope, their pain in that right lower quadrant will be at all times. But with lifting the thigh, that will cause that right lower quadrant pain to be worse when they're on their back.
Okay.
Mm-hmm. Yep, good question. All right, which statement by a mother may indicate a cause for her 9-month-old's iron deficiency anemia? She almost never drinks water. Formula so is expensive, so we switched to regular milk right away. I give her a piece of bread now and then, and she likes to chew on it. She doesn't like peaches or pears, so we stick to bananas for fruit. Yes, so switching babies before they're a year of age increases their risk for iron deficiency anemia because of the regular milk. Okay. So babies need to continue to be on formula to lessen their risk for iron deficiency. Good. All right, what is the most common nutritional deficiency in children? Megablastic anemia, iron deficiency anemia, thalassemia, or sickle cell anemia? Iron deficiency anemia. Yep, so they're just not getting enough iron in their diet from leafy green veggies, or they're drinking too much dairy milk, which lessens your iron level. Okay. Hereditary blood disorder that the red blood cells are in a crescent shape. Thalassemia, hemophilia, sickle cell anemia, or aplastic anemia. Sickle cell anemia. So remember, it's kind of that sickled shape, red blood cell with kids with sickle cell anemia, okay? So they call that a crescent shape. Good. All right, what regulates how many red blood cells are produced? Leukocytes, erythropoietin, erythrocytes, or neutrophils? Erythropoietin. Yep, good. Good job, guys. All right, what information should the nurse include in a teaching plan about home care for a child with hemophilia A? Children's aspirin should be in lower doses for joint discomfort. Do not permit interactive play with other children. If bleeding occurs, apply pressure, ice, elevate, and rest the extremity. A firm, dry toothbrush should be used to clean teeth at least twice a day. Good. Yeah, if bleeding occurs, make sure they're putting pressure, ice, elevating, and resting that extremity. Okay, good. What will the nurse teach the parents of a child with a low platelet count to avoid? Aspirin, Benadryl, prednisone, or caffeine? Yes, good. Aspirin. That's because aspirin is an NSAID, which lessens your platelets, right? So if they already have a low platelet count, it would be ideal for parents to avoid worsening that by giving them aspirin. Good. A child with leukemia has widespread purpura and a platelet count of 19,000. What is your priority nursing, or what is your nursing priority? Providing family education about how to prevent bleeding, inserting an IV, monitoring vital signs during platelet transfusion, and assessing neurological status. What is your priority? Assessing neurological status. Okay. Obviously, if they were getting platelets, you would make sure you're monitoring their vital signs just as you would with blood transfusions. But kids with low platelets and they're already having purpura, you get worried about bleeds in their brain, okay? And clots. So you want to keep an eye on their neurological status. Okay, which statement indicates an understanding of health maintenance of a child with sickle cell disease? He shouldn't receive any immunizations until he's older. He needs to wear protective equipment if he plays contact sports. It is important for my child to drink plenty of fluids. I should give my child a daily iron supplement. Okay, so kids with sickle cell disease, to prevent them from going into crisis if they're going to participate in a sport, is making sure that they stay hydrated. Okay, they're less likely to have sickle cell crisis if they remain hydrated. Good job. Okay, most common cause of anemia in children: thalassemia, hemophilia, iron deficient anemia, or hemostasis. Yes, iron deficient anemia. Good. Okay, what is a complication of repeated blood transfusions with a child with thalassemia major? Hemostasis, hemophthosis, hemoptosis, or hematuria? Hemostasis, okay? Okay, hereditary condition where the blood does not clot normally: thalassemia, hemophilia, sickle cell anemia, or ITP. Hemophilia. Good. All right. A recent blood count for a child who received chemotherapy shows neutropenia. What is the priority nursing diagnosis? Altered skin integrity, risk for infection, disturbance in body image, or risk for hemorrhage? Okay. Neutropenia is low neutrophils, which that's a part of your white blood cells, which fight infection. So if you have low neutrophils because of your chemotherapy, you're more at risk for infection. Okay, good. What type of cells carry oxygen and carbon dioxide in the blood? Platelets, albumin, erythrocytes, or leukocytes? Yes, erythrocytes. Good. Those are the red blood cells, right? What can occur if iron deficiency anemia goes untreated? Pulmonary embolism, hemorrhage, heart failure, or infection? Heart failure. Okay, so eventually they can become so iron deficient and so anemic from that they can actually go into heart failure. Okay, so it's really important to talk about how to prevent iron deficiency anemia. Okay, a multi-select. What skin assessments would alert the nurse to bleeding for a child with a low platelet count? Purpura, ecchymosis, petechiae, or lymphadenopathy? Purpura, ecchymosis, and petechiae. Those are all different forms kind of bleeding and bruising, okay? What is the name of the malabsorption problem that results in gluten intolerance? Intussusception, celiac disease, pyloric stenosis, or Hirschsprung's disease? Celiac. Good. All right, last question, then we'll do the PowerPoint. Hereditary blood condition where the red blood cells are crescent shaped. Sickle cell anemia, thalassemia, aplastic anemia, or ITP, which is idiopathic thrombocytic purpura. Sickle cell anemia. Good. All righty. Good job, Jasmine. Good job, whoever used the name Love. And then good job for Try. Okay. All right, we're gonna go ahead and go to Menti for our PowerPoint for this week. So if you guys can join me on Menti. Okay, so remember, go to menti.com and then just use this code to join. And then add some concepts. It looks like a couple of you guys have already done that. So some kind of questions or some things you're looking forward to learning today. Pyloric stenosis, yep, good. Anyone have anything else that they're looking forward to learning, or maybe that they have questions on after doing their reading? No?
I wanted to add something in there, but I never could do it the whole time.
Oh, okay.
And I forgot the name of it, but it's like when the child's rectum is not there.
Oh, imperforate anus.
Yeah, I wanted to learn more about that.
Yep, we'll talk about that. That's something that's actually more common than you would think. Okay. Alrighty. So, like I said, this week we're covering blood and lymphatic tissue information, along with like leukemia and lymphoma, and also GI. Okay. So we're going to start with the blood and lymphatic system. Here are your objectives. You guys are able to read those on the PowerPoint. So I will let you read that on your own time. Okay, so the lymphatic system, it drains regions of the body using the lymph system. So using the lymph nodes, okay? This is where infectious organisms are destroyed. Your antibody production is stimulated. And then enlargement of the lymph nodes is also known as lymphadenopathy. That can be caused from infections or disease processes like leukemia, okay, can cause enlarged lymph nodes. Also, really bad allergy flare-ups can at times cause enlarged lymph nodes, okay? And our lymphatic system is to hopefully drain that toxin out. But if it gets infected, then a lot of times it kind of pools onto that fluid and becomes enlarged. Your spleen is also a part of your lymphatic system. So this picture shows you a normal size spleen, and then this is showing splenomegaly, which is an enlarged spleen that usually comes from an infection of some sort. It's the largest organ within the lymphatic system, and its main function is to bring blood, to mix that blood with the lymphocytes. It enlarges during infections. It can be enlarged at birth. It can be enlarged from acquired hemolytic anemias, or if there's malfunction with the liver, okay? So circulating blood, it's two portions. So it's plasma, and then it's the formed elements, which are erythrocytes, leukocytes, which are white blood cells. Erythrocytes are red blood cells. And then thrombocytes, which are the platelets. Erythrocytes, your red blood cells, those carry your carbon dioxide and your oxygen to and from the lungs to the tissue. Your leukocytes are your body's like first response fighter system, okay? So those increase if there's an infection that's sensed, okay? And lymphocytes are produced in the lymphoid tissues of the body. Oh, goodness. Let me clear these. Oh gosh, it's showing I'm still learning this Menti. I think I forgot to reset it. Okay, so which type of cell is responsible for transporting oxygen and carbon dioxide to and from the lungs? It's the erythrocytes. We covered that in the Cahoots. Okay, hang on. I'm going to go back and reset all of this because apparently it didn't work when I reset it right before. So hang on one second. Okay, I'll try again here. Okay, what type of cell helps with clotting mechanisms? Erythrocytes, leukocytes, or thrombocytes? Good. Thrombocytes is correct. What is the other name for thrombocytes? You guys can just unmute.
Platelets.
Was it platelets?
Yes.
Platelets.
Good. Perfect. That is correct. Okay, what type of cell is the body's defense against infection? Erythrocytes, leukocytes, or thrombocytes? Oh, that's not correct. It's the leukocytes. I'm not sure why that one's showing up as wrong. I'll have to go back and fix it. The first cell is leukocytes for infection, okay? And those are white blood cells. Okay, anemias. This can result from many underlying different causes. The most common that we talked about in the Cahoots, remember, iron deficiency anemia, okay? Anemia is essentially a reduction in the amount of circulating hemoglobin, which then reduces the amount of oxygen that's carried to the body. So hemoglobin of less than 8 can result in increased cardiac output and shunting of the blood from the periphery, so your hands, your feet, to the vital organs, because it's trying to keep those organs functioning appropriately, and it's carrying less about circulation to hands and feet. Most common kids with anemia, you're going to see they're going to be a lot of times pale, they're going to be more fatigued, weak. A lot of times they're going to be tachypnic if it's severe anemia, and then they become a lot of times short of breath, and then eventually, if their anemia isn't addressed, then they get to the point where they have heart failure. So iron deficiency anemia, this we had talked about in the Cahoots or had questions on. It's the most common nutritional deficiency in children. Most commonly found during the 9th month to the 24th month of age, and then also during adolescence. And think about what's going on. Formula is getting expensive towards that 9th month, so parents might be switching out some of their formula bottles or some of their breast milk bottles with real dairy milk, which lessens their iron because it binds and replaces iron in the gut on the hemoglobin. Okay. It can cause severe hemorrhage. It can lead to the inability to absorb the iron that's received. And it can also affect growth. Okay. So some iron-rich foods are green leafy veggies, red meats, okay, shellfish, broccoli, chicken, things like that have a lot of good iron in them. But continuing to give those kids a lot of cow's milk can further worsen their iron deficiency anemia, and it can eventually get to the point where it causes GI bleeding. Okay, so it'd be important to talk to parents about cutting out real dairy milk. Okay, they could do something like soy milk instead. Okay. All right. So like I said, kids with anemia, just in general, a lot of times they're pale, so they have pallor, they're more irritable, they might not be as hungry, and you're going to see decreased activity. Okay. If babies are consuming excessive amounts of milk, you may also see infants being overweight or obese because they're getting too much milk intake. Okay. The blood test that you would do to find or to figure out that a kiddo has iron deficiency is a red blood count, or you could do a CBC, which looks at the red blood count in the hemoglobin and hematocrit. You want to look at the morphological cell changes, which is also on a CBC. And then you also want to look at the iron concentration, which can be in the form of just general iron or ferritin level, or a total iron binding capacity. All of those can kind of help you identify iron deficiency. Okay. Also, if there is any concern of blood in the stool or anything like that, then you will want to test for doing a Cold blood test. Okay. Yes, if you guys just need to run to the restroom, you're more than welcome to do that. Okay. So, like I said, untreated iron deficiency, that leads then eventually to the heart muscle becoming too weak to function and to heart failure. So you really want to make sure you're treating kids with liquid iron, okay? Kids who continue to have iron deficiency anemia, a lot of times their growth is going to be slowed, and a lot of times they'll have cognitive deficits because of the lack of iron. So usually you're going to supplement in the form of ferrous sulfate, which this is a picture of just a brand of liquid iron. You usually do that 2 to 3 times a day. And you also want to make sure that when those parents are giving those kiddos iron, they're also giving them some form of vitamin C. So usually I just tell parents, give them the iron with a little bit of orange juice, and that helps them to absorb the iron better. But also, like I said, if you're supplementing with iron, you want to make sure that you've talked with parents about eliminating their cow's milk intake, or at least significantly cutting back on that. Okay, parent education. So nurses stress the importance of breastfeeding for the first 6 months and or using iron fortified formula through the first year of life. Okay. So babies who are breastfed are also getting the iron through mom, through the breast milk through mom. Okay. But if mom consumes a lot of dairy or doesn't eat a lot of leafy green veggies, then their potential for iron deficiency is low or is higher as well. Stools of infants who are taking iron can be like a greenish color or almost like a black color. So just let parents know that change may be happening. Like I said, do not give the iron with milk, and also have that conversation about cutting back on doing milk at all for kids who have iron deficiency. And then making sure that they're giving the iron between meals when the digestive acid is highest, because that also helps with iron absorption. Okay, what are the causes of iron deficiency anemia? Rapid growth, depleted prenatal stores, weaning off of iron fortified formula, or not enough red blood cells. Okay, so rapid growth, right? Because kids are growing so rapidly from the ages of birth to 24 months, and then again during adolescence, that's going to deplete some of their iron stores. Okay, so rapid growth is a cause of iron deficiency anemia. Depleted prenatal stores, that is absolutely correct, right? Because babies have some of mom's iron until about 6 months of age, and then weaning off of iron fortified formulas. Good. Okay, critical thinking question. During a routine clinic visit, the nurse notes that an 18-month-old child has pallid skin, appears lethargic, and is overweight. The mother says the child has become less active and is increasingly irritable. What condition should the nurse suspect, and what education is appropriate? So you guys can unmute, or you can type in the comment box and add a comment. and I'll be able to see that. What do you think's going on with this 18-month-old? They're pale, they're lethargic, and they're overweight, and they're more irritable.
Deficient of iron.
Yeah, sounds like they're anemic, right?
Mhm.
So what would you educate these parents about then if they're having iron deficiency anemia?
Definitely do an iron supplement.
Uh-huh. And the baby's overweight, right?
Mhm.
So what is usually associated with iron deficiency and being overweight?
Overconsumption of milk.
Yes. So you would see how much milk they're doing, right? And recommend that they cut it out or at least significantly cut back on it. Okay. Good. What else? When they do their iron supplementation, what else should they do?
Should they do a red
Vitamin
blood,
C.
like the testing to see what the iron levels is?
Yes, you should do that to make sure that you're on the right track. But when you're giving them the iron,
Oh, vitamin C.
yes, exactly. Good. Good job, guys. All right, sickle cell disease. So this is an inherited defect, okay? So it has to come from both parents, okay? It's how the hemoglobin is formed and the shape that it is. So in this picture, you can see here's a normal red blood cell, okay? And then here's those sickled cells or the crescent shaped cells. You can kind of see them there. It's most common risk in African American population and also the population from the Mediterranean. Okay. It causes decreased blood oxygen level because these sickled cells cannot carry oxygen appropriately. Okay. It leads to dehydration often. They're at risk for infection. That can cause a sickle cell crisis along with dehydration. If there's any physical or emotional stress on that child, they can also have sickle cell crisis or exposure to cold. So you have to keep these kiddos bundled up because they're more likely to have crisis if they're exposed to cold. So there's two types of sickle cell disease. There's sickle cell trait, which means that they carry that gene, but they do not have sickle cell disease. Okay. So you can see here. So mom has AS and dad is AS. So both parents have the trait to pass on to that child. Okay. So there's a 25% chance with each pregnancy that that child will have sickle cell disease. Okay. So you can kind of see how it's inherited here. So if they're asymptomatic, a portion of their blood contains hemoglobin A, which is a normal hemoglobin, but also a portion of their blood is hemoglobin S, which is that sickled portion. If they're asymptomatic and they just have trait, then their hemoglobin S is not really a significant amount, so they don't have the concerns of full-blown sickle cell disease, okay? When you check these kiddos' hemoglobin levels and their red blood cells, they're going to be normal, okay? So kids with trait just inherit that gene from one of their parents, so they're not going to actually be symptomatic. Kids with sickle cell anemia or sickle cell disease, they're going to be symptomatic, okay? They're going to have anemia. They're going to be at risk for these crisis episodes, okay? So usually you don't start to notice symptoms of sickle cell anemia until towards the end of the first year of life. You may notice like swelling in the fingers or the toes, just because think of how narrow those blood vessels are in those areas, and it's a lot easier for these clotting crises to happen because of the sickled cells in those areas, and then they lead to the impediment of blood flow. So a lot of times you'll see swelling in the fingers and the toes, maybe some discolorations in those areas as well. The symptoms are caused from the enlarged bone marrow, and then that sickle cell interrupting and impairing that circulation. Okay. And it causes the obstruction of the blood vessel, like you can see here, right? And then it leads to ischemia past that. So here's the obstruction, and then the ischemia, or the dying tissue, then would be after that obstruction. Okay.
Question. So you
Yes.
say it's normally not, people won't know that they try to have sickle cell until the end of.
Symptoms. They don't typically have symptoms. Yep.
Okay.
So a lot of times, first off, if parents have already had children and they know that they have sickle cell trait, usually that's tested during prenatal care for at least the mom. So if mom has trait, then a lot of times they recommend testing dad to figure out if he also has the trait. But yes, it's symptoms do not begin until typically towards the end of the first year.
Okay, thank you.
Yes, you're welcome. Okay, so your manifestations of sickle cell disease. A lot of times kids are going to have headaches, dizziness. They're more at increased risk for seizures and strokes because of those occlusive events that they can have. They can also have eye problems or blindness because of the risk of the occlusive events. Shortness of breath, chest pain. The biggest thing is when they are in sickle cell crisis, they're gonna have significant pain from those obstructions or those occlusions, okay? So making sure that they're hydrated and reducing the risk of those obstructions and those occlusions is gonna be very important. They may have severe abdominal pain, leg pain, swelling, swelling in their joints. It kind of just depends where that occlusion is occurring and all of their symptoms, but eventually it can be fatal if it's not addressed, that occlusion's not addressed, okay? Fever, vomiting, convulsions, stiff neck, coma, paralysis can result. Like I said, if it's an occlusion, in the brain, the vessels of the brain, then you're more at risk for severe complications. Okay. And with sickle cell disease or anemia, they actually have the disease, okay? Their hemoglobins are going to be lower, usually 6 to 9 range, okay? So vaso-occlusive crisis, that's going to be that painful crisis where they have that occlusion of the vessel and they have pain because of that. Splenic sequestrian, that's another form of sickle cell crisis. So that's usually when the spleen's involved, okay? Still gonna have pain. Aplastic crisis, that's where their anemia is getting more significant, causing them to have crisis. And then hyperhemolytic, so they're having like a traumatic event that's causing a lot of blood loss. So those are kind of the 3 or the 4 different types of crisis that you can see with sickle cell. Okay, so your CJ Sims for this week, we're going to talk about Raymond James. He's a 16-year-old adolescent child. He's presenting with fever, joint pain in his knees, shortness of breath with exertion, and fatigue. He told me he's stressed out and not sleeping well. Raymond was diagnosed with sickle cell anemia at 9 months of age. His parents are extremely vigilant in his care. He has only been hospitalized 3 times since his diagnosis. Once at 9 months of age for diagnosis and stabilization, then again when he was 5 years old in a thrombotic occlusive crisis because he was having pneumonia. And his 3rd hospitalization was at 13 years of age. And he had to have IV and oral chelation. Throughout his school age years, he was treated with penicillin prophylaxis and home oxygen saturation monitoring. Okay. The home oxygen was only needed to prevent hypoxia. Pain has been managed with Tylenol and Tylenol with codeine. He's receiving periodic transfusions and red blood cell exchanges as an outpatient. He's required several blood transfusions in the last 8 months, with the most recent one being yesterday at the outpatient center. He is now here because he's having a vaso-occlusive episode. Okay. Oh, so what are you going to do for this kiddo? What's going to be your priority as a nurse? We're going to make sure he has an IV, right? Because he's going to be having a lot of pain, right? What else are you going to use his IV for?
Fluid and morphine.
Yep, fluids. Yep. So he's going to be getting IV fluids. Yep. And then he might need morphine or some other opiate kind of pain medication, right?
Mm-hmm.
What else? What do you think his vitals are going to look like? With him being in vaso-occlusive episode.
He may have a high blood pressure.
Yeah. What else?
Tachy.
Uh-huh.
The tachycardia, tachypnea.
Well, one's for breathing and one's
Right.
for heart.
I'm sure he may have increased heart rate.
And he may have tachypnea too, right?
Yes, because he's trying to breathe with the pain.
Yep.
And
Exactly.
then the sickle is like cutting off the oxygen too, right?
It can, depending on where the occlusion is. Yep. Good. Yep. So he might have some shortness of breath, right? From the pain and from depending on where the occlusion is. Good. Yeah. So your biggest goal is going to be figuring out if there's some infection that caused this episode. Or, did he just get dehydrated and need some fluid to kind of get him through? But yeah, pain management and hydration is going to be your biggest things to look for. Good. Okay, here's your objectives for 27.2. Okay, good. Thalassemia. So thalassemia is a group of hereditary blood disorders where they do not produce enough adult hemoglobin. Okay, the red blood cells are shaped more kind of like rectangular versus being nice and circular. And because of their abnormal shape, they are destroyed more rapidly than typical red blood cells. Okay, so then this leads to chronic anemia. Your body attempts to compensate for the lack of adult hemoglobin by producing fetal hemoglobin. Okay. So thalassemia is categorized based on the polypeptide chain that is affected. So there's beta thalassemia, that's the most common type of thalassemia. It involves impaired production of the beta chains. So there's thalassemia minor and there's thalassemia major, and we'll go into those a little further here. And then it can also happen from potentially just spontaneous mutations in those polypeptide chains. So thalassemia major, Cooley's anemia it's severe anemia, and it usually presents within the second 6 months of life. So from 6 months to a year of age is when you start to see kids have symptoms, and that's because what's happening, those prenatal stores of iron from mom are decreasing right after 6 months of age. So that child's system has to take over. You are at more risk for hemosteatosis, which is iron deposits in the tissues, okay? Instead of on the blood cells, they build up in the tissue, okay? And then this can eventually result in cardiac failure because of the severeness of this anemia. Kids are going to be pale, they're going to have low oxygen or hypoxic. A lot of times they have poor appetite, fever. They may be a little bit jaundice because their liver is eventually affected because of the red blood cell destruction. They may also have a slightly enlarged spleen because of that red blood cell destruction as well. Kids with Cooley's anemia also have a lot of times facial abnormalities. So you can kind of see, she has a little bit more of a flat nasal bridge, a little more kind of a forehead or a more flat forehead. And then these kids require frequent blood transfusions with thalassemia major. Okay, which ethnic population is mainly affected by thalassemia? Now we talked about this in the Kahoot questions.
Can you repeat that again?
So what ethnic population is mainly affected by thalassemia? And your options, you're on your Menti. You should be able to pick your options: Native Americans, Mediterranean, or Hispanic. And we had talked about, this was one of the questions on our Kahoots.
I can't remember if it's African Americans and
Mediterranean is going to be the
Mediterranean.
correct answer for thalassemia.
Oh, so it's only Mediterranean?
Yep, Mediterranean. Yep.
Okay, the sickle cell one is African American.
And
okay.
Mediterranean. Yep, both.
Oh, both. Okay, both of
Yep.
them. Got you.
Yep, good. Good job. All right, hemophilia. So this is it. Once again, an inherited sex-linked recessive trait. Okay. The defect gene is on the X chromosome. Okay. Fetal blood samples can detect hemophilia. This is most common that it's found on our newborn metabolic screenings that each state has a little bit of a variety of different tests that they do, but hemophilia across the board has to be tested for. The two most common types are hemophilia B, which is also known as Christmas disease, okay? And that's a factor 9 deficiency, or hemophilia A, which is factor 8 deficiency, okay? And then with hemophilia, you have either a deficiency in the factors that go along with blood clotting. So like I said, hemophilia A is factor 8 is affected in the clotting cascade, and hemophilia B or Christmas disease is factor 9 is affected. Oops, goodness. So hemophilia A is factor 8 is affected, okay? So the severity is dependent on the level of factor VIII in the plasma. So some patients can be really endangered in losing a lot of blood, even with a minor scratch, if their factor VIII is very deficient, okay? But others might just have a little bit of more easily bruised than the typical person if their factor VIII isn't totally deficient. The aim of therapy is to increase the factor VIII to make sure that kids with hemophilia A are clotting normally. One of the key tests in figuring out how our blood is clotting is a PTT, or a partial thromboplastin time. So that looks at how long it takes that blood to clot. So if kids are really deficient in factor VIII and their hemophilia is pretty significant, their hemophilia A is pretty significant, then they're going to have a really delayed or long, high number of time that their PTT takes to clot. Okay. So it's typically diagnosed at birth, okay, because babies cannot get factor VIII from their mom. Okay, they cannot cross that placenta. So a lot of times, you know, babies will prolong bleed after they have something like a circumcision, or if they have some sort of, you know, a lot of leaking at their umbilical stump, you know, after they cut their umbilical cord, there's a lot of blood leaking, or they have a really hard time getting that to stop bleeding, then you would get concerned that that kiddo may have hemophilia. Okay. Normal, typical blood without hemophilia clots within 3 to 6 minutes. You know, of course, applying pressure in that time frame as well. But in severe hemophilia, it can take an hour or longer to clot, even with holding pressure. Okay. So if you guys are helping a provider with a circumcision and, you know, the baby's really bleeding a lot and you're applying pressure and they're still bleeding a lot and their blood's not clotting, then you would be really suspicious that they have hemophilia. Okay. So kids with hemophilia, obviously, because they're at risk for prolonged bleeding, they may have more anemia. They may also have leukocytosis, right? And a moderate increase in the blood cells because of the amount of hemorrhaging. Okay. Or excuse me, I said blood cells, I meant platelets, because those platelets are trying to aggregate. So they're trying to all collect together to slow down the hemorrhaging. But because they do not have those factors that go along with the clotting cascade with platelets, you know, they continue to bleed. You may see signs of shock if kids have lost a lot of blood volume from bleeding. They may have spontaneous hematuria, so they may have, you know, not had blood in their urine, and then all of a sudden they start having blood in their urine. You then get concerned about, you know, some sort of internal injury causing blood in the urine. And of course, you know, if they continue bleeding and you can't get that bleeding to stop, then they can they can die, especially if that bleeding is occurring in their brain or, you know, near their neck. A lot of times severe headaches, vomiting, or disorientation, so changes in their neuro assessment are noted in kids with hemophilia or, you know, bleeding. Okay, what lifestyle modifications will a child with hemophilia need? And you guys can just type these on here. Or you can unmute, whichever works. Okay, what lifestyle modifications do a child with hemophilia need? Do you think that they can play contact sports?
No.
Yeah, you'd probably get concerned about that, correct?
Mm-hmm.
Yeah. Staying hydrated, yeah. Monitor for bleeding if they have an injury. Yeah, good. What else? Bruising, yeah, because that bruise potentially it could just look like a bruise on the surface, right? But underneath there could be a lot of bleeding that's happening internally. Okay, good. Okay, parents of a 9-year-old boy are confused about their son's diagnosis and treatment of hemophilia A. They don't want to exclusively limit their child's activities, but they are concerned about how to prevent bleeding and treatment if that occurs. What information or counseling should the nurse provide? So what would you tell these parents? Do you remember on our Kahoots about the ice, the resting?
Elevation.
Yep, yep, that goes on with hemophilia. So if they start to notice a bruise, that would be some things that they could do. Or
Go
eventually,
with the ice.
what? Go ahead.
What the ice pack with the bruising?
Mm-hmm. Well, it what does ice do? Constricts, right? Those blood vessels.
Yeah.
So it's more
Mhm.
likely to kind of help to prevent the significant bleeding. Mm-hmm. What else? They're probably also going to have potentially maybe need to get factor 8 infusions or be given, take factor 8, right? Or factor 9, depending on which type of hemophilia they have. But in this case, it's hemophilia A. So it's factor 8. Mm-hmm. Good. But yes, the rest, elevation, ice, all of that goes along with hemophilia. Okay, platelet disorder. So thrombocytopenia is going to be when your platelet count is less than 140,000. Okay, so that means a low platelet count. Okay, because of this destruction of platelets, that's going to interfere with the clotting mechanisms of the body. So similar somewhat to hemophilia A, but this is purely from the number of platelets instead of the clotting, or instead of the factors that are involved in the clotting cascade. Okay. Does that make sense to everyone? You understand kind of the difference? They kind of go hand in hand a little bit, but this is looking at platelets specifically. So types of skin lesions that you can see with kids with platelet disorders or thrombocytopenia, they can get petechiae, which are little tiny bruising of the capillaries, purpura, which can be a little bit bigger bruising that's usually seen like on the legs and the thighs, ecchymosis, which is like your classic bruise, and then a hematoma, which that would be a bruise, but also would have a collection kind of blood along with it. So idiopathic or immunologic thrombocytopenic purpura is the most common type of purpura. And actually, special little fact, I guess, I actually had ITP when I was 3. And I haven't had thankfully, any long-term issues, and I haven't had any further episodes of ITP, but essentially, how it started for me was I had been sick with just like a viral kind of illness. And then my body just had an autoimmune reaction after that illness. And I started having a bunch of bruising on my legs. And essentially, what ITP is your platelets recognize themselves as kind of a foreign entity. So then those anti-platelet antibodies then start attacking your platelets, and all of that destruction occurs in the spleen. Okay, so then because your body's recognizing your platelets as foreign and destroying them, then you're going to have a really, really low platelet level. Okay, and you're going to be at increased risk for bleeding. And also, what goes along with platelets? They're a part of kind of our immune system, right? So you might be more at risk for infection as well. Okay. ITP can happen in any age group, but it's most common between ages 2 and 4. Kids with ITP, so you can see here the purpura, it's kind of more of a collection, a little bit bigger of a bruise. And then the petechiae are a bunch of kind of little tiny bruising spots. Okay. So with ITP, you're going to see both petechiae and purpura typically, but you're going to see more purpura. It can happen after viral respiratory illness, like in my case, rubella or rubeola, which we do have vaccines now against rubella and rubeola, which is German measles. Rubella or rubeola is German measles, but so our MMR vaccines help kind of cover that, but we still see ITP. Usually you see ITP happen about 2 weeks after the illness or exposure. Platelet counts are a lot of times less than 20,000. So these kids are really at risk for bleeding because their normal range on a platelet count is 150,000 to 400,000. So less than 20,000 is really significant. They confirm the diagnosis by doing a bone marrow aspiration. So they do a bone marrow tap kind of in that hip, like your pelvic kind of bone on your iliac crest a lot of times. And then they pull some of that bone marrow out, and they will see that the platelets are really low in the marrow, and that's how they go about diagnosing ITP.
So I got a question.
Yeah.
Is ITP some type of form of thrombocytopenia?
Yes.
Since
Yep.
so
Yep.
is a type of the word it's a long
Yep,
word.
thrombocytopenia. You were saying it perfect. Yep, that's correct, because thrombocytopenia is low platelet count,
Mhm.
low
Right.
thrombocyte count.
Okay.
Yep. And kids
So,
with
but then,
ITP are going to have like no platelets.
okay, so like the hallmark of the ITP is like it'll be less than 120,000.
Less than 20,000.
20,000. Great. Dang.
Yes. Yes.
Okay.
Yep.
So in general, if you come into the hospital and they do your little CBC and they see that your platelet counts is lower than 140, that's like in the range of thrombocytopenia. But then if it's lower than 20,000, they'd be like, okay, that's ITP.
So it doesn't mean for sure that they're diagnosing ITP, but it makes them more suspicious of that. So for ITP, they have to have that antiplatelet antibody has to be present as well.
Okay.
Yep. Because kids with different types of cancers like leukemia or lymphoma, their platelets can be really low as well.
Right.
But
Okay.
with ITP, their platelet counts are going to be pretty low. And the way that they used to think that you treated ITP was by giving kids more platelets, but that leads to further platelet destruction because you still have those platelets getting coded in that antiplatelet antibody code. Okay. So now they've figured out to do, it's called IVIG. It's a collection of immune globulin from a bunch of donors. Okay. And then it looks just like this in these bottles. Oh, it looks just like this in these bottles. And then it's just kind of given via IV, like a usual transfusion. They may also need to be on an anti-D antibody or on prednisone or steroid. Okay. But a lot of times giving just the IVIG is beneficial enough to kind of kick the ITP and get rid of that antiplatelet antibody recognition that was going on. Okay.
Okay.
And a lot of times kids just have one episode with ITP and then it does not ever present again. But there is a form that kids can have recurrent or chronic ITP. And then in that case, they need to have their spleen removed.
Mm.
Okay. And you want to make sure you're doing neurological assessments on kids with ITP because of their low platelets, put them at risk for having bleeding, in the brain or clotting, like strokes. So because platelets are low, you're not going to want to give medications and things that can worsen platelets destruction. So you're going to want to make sure that these kids are not getting aspirin, that they're not getting caffeine. And if they are having an episode of their ITP, you're going to want to limit their activity. So that way they're avoiding bruising, just kind of what you do like with kids with hemophilia. Okay. And like I said, it used to be a thought that we give kids platelets with ITP, but that's no longer what's recommended. It's doing the IVIG because if you just give them platelets, they're just going to continue to burn through those platelets. Okay. All right, complications of ITP, bleeding from the GI tract, hemoarthritis, so that's bleeding into the joint space. Okay. And a cranial hemorrhage. So like I said, that's why you want to make sure you're keeping an eye on their neurological status. And then preventing ITP from happening, of course, by making sure that these kids are immunized for viral childhood diseases like with the MMR vaccine, okay? All right, what is the rationale for splenectomy? To prevent infection, to increase the patient's clotting factors, to stop the destruction of platelets, or to decrease the number of platelets produced.
What was the word again? You said splenectomy?
Splenectomy, yep,
Spleen.
yep. What does ectomy usually say?
Like incision or some type of
Removal?
removal
Yep.
of the spleen.
Yes, there you go. Yep, removal. Just like tonsillectomy, removal of the tonsils. Yep.
Yeah.
So remember at the beginning of this, I said that the spleen is where a lot of the platelets are destroyed with ITP. So by removing the spleen, you hope to then reduce the destruction of the platelets. Spleen does play a factor in infection, right? But in this scenario, we care about removing it to stop the destruction of the platelets. Okay. Good. All right, here's your next objectives for 27.3. You guys can read those. Disorders of the white blood cells, such as leukemia. Okay, so leukemia is the most common form of childhood cancer, okay? Also happens in adulthood, but it's the most common form of cancer in childhood. It's a malignant diseases of the bone marrow and the lymphatic tissue and lymphatic system, okay? There's two common types. There's more chronic types as well, but the most common acute types are acute lymphoid leukemia, or ALL, or acute non-lymphoid or myelogenous anemia, or AML or AMLL, okay? So those are just two different subdivisions of leukemia, okay? The ALL is the lymphoid tissue is affected, and the AML is where the lymphoid tissue is not as affected, where it's more the bone marrow. And they figured that out based on a biopsy of the bone marrow that they do after they do the bone marrow aspiration, just like they do with ITP. They do the tap on the iliac crest, they pull out that bone marrow and look at it with a microscope and do a biopsy. Okay. So when they're looking at that biopsy, you'll see different chemical markers and different chromosome testing studies that they'll do on it, and then different immunologic markers too, to kind of figure out which type of leukemia that kiddo has. So with leukemia, the blood forming organs, so the bone marrow and the spleen, right, and the lymphatic tissue are all involved. So what happens is there is a huge amount of immature white blood cells created, okay? Because there's a disruption in the bone marrow function. Your bone marrow, because of the leukemia, freaks out essentially and starts thinking it needs to produce a lot of white blood cells. But because it's in panic mode, it's just producing and releasing immature white blood cells instead of allowing them to mature. Platelet counts will be reduced in kids with leukemia, kind of what we talked about with Latricia when she was asking about ITP. Okay, platelet counts will also be low in kids with leukemia. The invasion of the bone marrow causes weakening of the bones, and you can see like fractures from that bone weakening because of the invasion of the bone marrow with those immature white blood cells. Okay.
So this one is more, I'm just trying to
This is,
remember them. I want to get it confused. So leukemia is more about the bone marrow. I mean, since I guess the bone marrow has all of
it
all of
creates
this.
all the cells, right? The white cells, especially the white blood cells. So leukemia is a malignant form. So this is a cancerous form.
Cancer. Okay.
Whereas ITP is not cancer. It's just
Okay.
that antibody is recognizing it as foreign and attacking it.
Okay.
If that makes sense.
Yeah.
Okay, so here's another question to think about. Compare and contrast how an adult with leukemia might present versus a child with leukemia. How will their courses, so how they present and maybe what they're treated with, will be the same, or will they be different? So if your body's making a lot of immature white blood cells, do you guys think you can fight off infections very well?
No.
No, right? Even though your white blood cells, might be higher, you're not going to fight off infections very well because they're all immature. Okay. So both adults and children with leukemia are going to be more prone to infections and illnesses. Okay. Kids with leukemia are going to be more likely to be dehydrated, pale, fatigue, whereas adults with leukemia might hold it together a little bit longer on the hydration piece. Okay. Okay. And will their treatment be similar? So treatment for leukemia typically involves chemotherapy.
Yeah. So no, they'll be different.
Yep. The treatment is slightly different in adults versus children. Children, a lot of times, they'll also have prednisone or steroids as a part of their treatment. Okay. Children look sicker than adults. You're correct. Mostly because they can't course correct as well as adults. Good. Okay. Nursing care of a child with leukemia. Obviously encourage that child to verbalize their feelings, giving them permission to, be upset, and try to work through that scenario of being diagnosed with leukemia. Okay. Making sure that you're trying to clarify if kids are or when kids are having isolation troubles, right? Or they're wanting to isolate or maybe becoming depressed. Hey, Kiara, sorry. Your when you logged back in, it says Karen's iPhone. So can you just change it to your first and last name? I'm assuming you were probably having some troubles with your other device. Just so that way you get credit. Your biggest concern in these kids with leukemia obviously is going to be infection, right? So you as a nurse is going to be monitoring their temperature, their vital signs, all of that. You're also going to be watching for bleeding because of the thrombocytopenia, or their low platelet count that they will also have, okay? You also want to make sure you're doing really meticulous mouth and skin care, because if, first off, chemotherapy can sometimes cause mouth sores. But if kids get those mouth sores, or if they get sores on their skin, you're more at risk for infection and you're already immune compromised from your leukemia. Okay. So you want to make sure that you're keeping an eye on all of that as a nurse. Okay. That was kind of a quick overview of the most common things related to hematology of the child. Okay, make sure if you guys have not read, you read. Okay. All right, on to GI. There's your objectives. You guys can read those. You have the PowerPoint. So your GI system, that's going to transport and metabolize your nutrition. That is absolutely necessary for the life of the body and the cell. It extends from the mouth to the anus. That's your whole GI tract. And your nutrients are broken down and absorbable by enzymes from various digestive organs. So your stomach, your pancreas, your intestines, your gallbladder, those all contributed to breaking down those digestive enzymes and absorbing the nutrition. So symptoms of GI disorders. So systemic signs are failure to thrive. So that means failure to develop according to their established growth parameters. So if that kiddo was on 50th percentile and has been 50th percentile for all of their life, and all of a sudden they're dropped down, their weight or their height is dropped down to 20th percentile, you're going to get concerned about, is there something, what's going on that's causing their failure to thrive? Pruritus or itching in the absence of allergy may also indicate that there's something going on with their liver. So if kids are really itchy and you've sent them to an allergist or they've seen an allergist and they don't have any allergies causing the itching, then you get concerned about there potentially being some liver dysfunction. Signs of GI disorders, obviously vomiting, diarrhea, constipation, throwing up, blood, which is hematemesis, rectal bleeding, and abdominal pain. Those are all signs of GI disorders. Congenital disorders, so esophageal atresia or tracheoesophageal fistula. We had a question on this in the Kahoots, and I kind of touched on this briefly. So essentially, you can see here in this baby, the trachea has a path straight to the lungs, but the esophagus does not have a path the entire way to the stomach. And actually what happens is a lot of times the esophagus kind of makes an opening off of the trachea. So you go to feed baby, and what happens is the food should come down the esophagus, right? But there's not a full pathway. So what happens a lot of times is it backflows then into the trachea, because that's the path of least resistance that it can take. And then it goes partially to the lungs from the trachea, and then, down the esophagus as well, potentially. What you're going to see with these kids is, first off, they're not going to want to eat. And if they do eat, they're going to have a lot of choking, gagging. They're going to have shortness of breath, all of that. There's 4 different types of TEF or tracheoesophageal fistula. The upper and the lower esophagus from the stomach end in a blind pouch. So you have like kind of a double whammy with the esophagus path. So instead of having, one straight line, and in this picture, you have kind of one off put, you have 2. The esophagus, the upper portion, is also off of the trachea. This is showing the upper esophagus ends in a blind pouch. So that's what's showing here. So there's your esophageal atresia, which is the blind pouch. And then the lower portion of the esophagus is connected to the trachea. You can have the upper esophagus is connected to the trachea, and the lower esophagus is also connected to the trachea. Or you can have the upper esophagus connects to the trachea, and the lower esophagus has just a blind pouch, so it doesn't connect to the stomach portion. Okay. So like I said, these babies, the first time parents go to feed them, they're going to, turn blue. They're going to look like they're really coughing. They're going to have respiratory distress. Imperforate anus. Okay, someone was excited to learn about this. So this means that their GI tract and their anus, it should come from 2 separate types of tissues during fetal development. And once they meet, then that perforation happens, which creates that opening, allowing for the passageway or the anus to be created. But what happens in kids with imperforate anus is that perforation does not take place, and the lower end of the GI tract and the anus are just like a blind pouch. So obviously, if babies aren't having stool, you should be able to see that child doesn't have an anus, but sometimes it's less easy to spot depending on the severity of it. So what can happen is then that child just is not passing stool. So if parents notice that child's not having a stool, or they haven't had a stool within a certain amount of time, then you get concerned about imperforate anus. So like I said, it just means that it kind of ends like that last picture that we showed with the esophagus kind of ending in a blind pouch. That's essentially what happens at your rectum. Okay.
Oh, is it there? Do they have one? I didn't see it on the picture. Like it looked like the whole thing was completely disappeared.
They don't have an anal opening, essentially. They still have a rectum. It just ends kind of like inside, so you can't see. So what has to happen is they have to have surgery and have that opening created.
Oh, oh wow. Okay. I was
Okay.
thinking like maybe it have to be on a colostomy bag or something.
Well, sometimes if it's a significant defect, then they may have to do that. But a lot of times they have that opening created because they still have the GI tract portion that they should have on the inside. It's just that opening wasn't created.
Gotcha. Okay.
Okay. Okay, here's another CJ sim. Okay. Mario was nursing well for the first week after I delivered him. Last week he started vomiting after his feedings. I didn't think too much about it at first since my first son had reflux. This week he has been throwing up more frequently. He vomits with every feeding now, and sometimes it isn't good. This morning, the vomit flew across the room. There was a little blood in it also, so that's why I called for an appointment. He's usually calm after eating. Now he is very cranky, and I'm worried that he's losing weight. What do you think is going on? So, pyloric stenosis, right? Remember we talked about in the cahoots the throwing up that hits the wall or is very forceful is pyloric stenosis. So, okay, I didn't have more on that, I guess. So with pyloric stenosis, when you actually touch that kiddo's abdomen, you will feel at the top of their stomach a hard sausage-like or olive-like bump or mass. Okay. And that's just because that pylorus is getting like enlarged. So it doesn't close all the way essentially. So what has to happen if those kids have to have surgery to do that repair. The pyloric stenosis. Okay. But these kids will present, they'll have very forceful vomiting, or parents will tell you that, and then you'll feel their belly and you'll feel that sausage or olive shape in their upper abdomen. Okay. All right, celiac disease. I'm going to keep going. You guys can log off at any point now, but I'm going to keep going for those of you guys that want to keep going. Celiac disease, like I said, this is a gluten issue. It's a gluten enteropathy and spurae. So it leads to malabsorption in children. It's typically inherited, but it's kind of dormant until it's triggered by a lot of times environmental kind of triggers. So eating a lot of gluten can then throw it into like being full-blown celiac disease. Symptoms usually don't present until 6 months to 2 years of age when kids are eating more gluten prepared foods or gluten including foods like wheat, barley, oats, rye. Okay. Kids a lot of times will have look malnourished or like they have malabsorption because that's what's going on with kids. They also a lot of times have atrophy of the buttocks and the upper legs. And then the abdomen is also a lot of times descended. So this is a kiddo or a couple of kiddos that have celiac disease and kind of present that way. So essentially what happens is that the gluten damages the villi. So that's what helps with peristalsis in the intestines, and then they cannot absorb the way that they should. So then it leads to malabsorption. So there's multiple different types. There's silent celiac, which is atrophy of the intestines, which you see during a biopsy, or you get a positive blood test for tissue transglutaminase, which is what you look at with celiac. Or one of the kind of diagnostic tools of celiac. Atypical, which is the duodenum, is affected only. And then they kind of have mild GI symptoms. They might have a little bit of anemia, fatigue, or peripheral nerve kind of issues. And then classic is the atrophy of villi across the small intestine, which then leads to malabsorption, diarrhea, and abdominal pain. Latent, they do not have atrophy, but they may have like reoccurring rash with wheat intake. Okay, which of the following foods can patients with celiac disease eat?
Is it that whole grain?
Oh, they're on this list here. Vegetables, rye, barley, fish, oats. On Menti. Can you see that there?
No, I can never see it. I always.
So vegetables, rye, barley, fish, oats are your options.
Okay.
So vegetables and fish. Rye, barley, and oats, unless they're gluten-free oats, are all no-goes for kids with celiac because rye and barley are forms of, they have wheat in them and gluten in them. And oats typically do as well. Okay, Hirschsprung's disease or aganglionic megacolon. So this is absence of the ganglion innervation, so the nerve, the ganglion nerves within a portion of the bowel. It's usually in the sigmoid colon, in the lower portion of the sigmoid colon. So then this leads to lack of normal peristalsis because it doesn't have that nerve signaling that it needs to move the food along, and it results chronic constipation. They're going to have ribbon-like stools because it's only passing through a narrow portion of the colon. Portions of the bowel may be obstructed, and then that leads to abdominal distension. Okay, so there's an obstruction, and then the bowel after that enlarges, right? Because the stool's not moving through, so they're going to be more constipated, which makes your bowel larger as well. And then that leads to abdominal distension. It's more common in boys or kids with Down syndrome, and it can be acute or it can be chronic. I'm going to run to the bathroom really quick, then we can keep going if you guys want to.
Is everyone understanding this so far? Like, this gonna be a huge chapter.
I am, but this chapter we've already went over in med-surg. So our professor is pretty good at explaining this stuff for us.
That's good. I went over it too in med-surg. It's some new ones that I never heard of, like the ITP. This is my first time hearing about that. Yeah.
Okay. So you get concerned of Hirschsprung's disease if infants, newborns have not passed their meconium stools within the first 24 to 48 hours. Okay. So if they're having meconium after the 48-hour mark, then you might be concerned about Hirschsprung's. It's going to present with those ribbon-like stools. They're going to have an abdominal distension. They're not going to want to eat, and they're not going to be growing appropriately. Young kids, you can see Hirschsprung's happen if they've been given a lot of laxatives to treat the constipation. So you can see in this picture that here's your normal colon, has all those nerve endings that it needs. But in Hirschsprung's, you see the less nerve endings, and then, okay, eventually there's no nerve endings any longer. So then after that, you're going to see a buildup of constipation. Okay. Also, if they're throwing up bile, that's another sign of Hirschsprung's as well. So if untreated, then it can lead to an intestinal obstruction. It can also lead to inflammation of the small bowel and the colon, or enterocolitis, which these kids will have fever, explosive stool, and they'll be really worn out. You diagnose Hirschsprung's by usually a barium enema, which is what this picture is showing. So they injected barium, which is essentially a dye, into the colon. And they can see, you know, the passage of the colon there, okay? And you can see here's that enlargement, okay? They also will do a rectal biopsy or the anorectal manometry, which is where they look at the pressure in the anal sphincter. So it's going to be a really high pressure. Okay. Intussusception. So this is that telescoping of the intestines that we talked about in the Kahoot. So it's a slipping of one part of the intestine into the another part just before it or below it. Okay. It's often at the ileocecal valve. The mesentery can also be affected. So that whole tissue then kind of telescopes and comes in, and the mesentery tissue can also telescope in. You can see that here in that picture. So you're going to see blood and mucus and no feces for 12 hours after the onset of obstruction. And then after, then they're going to have those current jelly stools. Okay. Obviously, if this isn't corrected, then you get worried about strangulation. Okay. And obviously, if it's strangulated and it continues to enlarge and swell, eventually it can burst, right? So then your colon, your small intestines then burst, and then it leads then to peritonitis or infection then in the abdomen. Okay. So treatment of intussusception, it's an emergency. It needs to be diagnosed based on the history and your physical findings. You'll feel that sausage-shaped mass in the right upper quadrant with kids with intussusception. Okay. And usually what they do is just like with the megacolon, you have that barium enema. So they put that dye into your colon, and sometimes they'll even do an air enema, which sounds crazy, but then essentially what happens is a lot of times it reduces that intussusception, so they don't have to have surgery. But if the air enema is done or the barium enema is done and it is not reduced, then you have to have surgery on it. Okay, hernias. So inguinal hernia, that's a protrusion of the abdominal contents through the inguinal canal in the groin, okay? So these are both showing umbilical hernias, not inguinal hernias. Umbilical hernias are protrusion of a portion of the intestine through the umbilical ring. Okay, so those abdominal muscles just didn't fuse like they should have, so then that tissue kind of protrudes through. The tissue protrudes through more if kids are straining or if they're crying. Okay. Usually if you can reduce them, so that means push that part that's protruding back in, and it's an umbilical hernia, then you don't worry about doing surgery unless it still continues after they're 3 or 4 years of age, then they do surgery. Inguinal hernias, however, do surgery right away. Okay, a nurse is conducting teaching and discharge planning for a child who was scheduled to undergo a GI surgery. What should the nurse tell them? So what should your discharge teaching be with a kiddo that just had a GI surgery?
Splinting.
What do you mean by that, I guess?
Oh, like if holding a pillow against you, like if you got a cough or
Oh,
something.
yes. Yep, good. What else?
I guess the diet have to be what
They
a
might have
liquid.
to, yep, they might have to have a liquid diet or some other form of diet. Good. What about if they get a fever, right? That'd be concerning potentially for infection.
Yeah.
I was just gonna say, watch for signs of infection,
Yep,
redness, bleeding, opening of the
wound.
surgical site.
Yep, good. Bloody stools, right? That might be a concern. Maybe there's some bleeding still going on. Yeah, good. Okay, do you guys want to keep going, or do some of you have questions on the exam concepts?
Exam.
Uh-huh.
I have a lot, I don't know, in towards the Down syndrome, but I don't remember studying much on Down syndrome. May have, I just don't remember. So many 4 classes is a lot right now. So I'm
Yeah.
just like all over the place.
No, that's okay. All right, are the rest of you guys gonna hop off, or do you want to stay on?
I just have a question when you have time about my attendance, because I feel like I didn't miss that much, but I've gotten a warning already about my attendance.
Okay, yeah, let
But
me
I
look.
feel like I've only missed like an hour of my attendance of class.
Okay, yeah, I'll double check that.
Okay, thank you.
All right, those of you guys who don't want to stay on for or you don't have specific questions about concepts from exam 2, then you guys can hop off.